Move on to the next one by Dr. Brightlin from Medicine 4 on blood, sweat, and tears.
Good morning, everyone. I'll be presenting on behalf of Medicine 4, Blood, Sweat, and Tears. So coming to the case scenario, Mr. S, 53-year-old gentleman, who's welding worker from Tirupattur, came with complaints of imbalance while walking for 3 days. He noticed when he tries to walk that he feels as if he's about to fall. He also had vomiting for 1 day, which was non-projectile. 1 episode per day he had. There is no history of bile or blood or bile stain vomitus. There is no history of LOC sheets. There is no history of blurring of vision, diplopia, no deviation of angle of mouth, no drooling of saliva, no cough while eating food. There is no history of sensory disturbance and no bowel and bladder disturbance. Past history is a diabetic for 6 years. He's not on any medications for the same. So also a chronic alcohol consumer for 10 years and consumes 80 ml whiskey per day. So examination findings, he had memory disturbance in the form of he was not able to recall his marriage year or the daughter's age. Speech was normal. Cranial nerve, his second cranial nerve pupils are bilaterally reacting to direct and indirect reflex. But on confrontation test, the patient was not able to see towards his right side. So there was right homonymous hemianopia. He did not have any other cranial nerve deficit. So motor system, his power was 4 by 5 in right upper and lower limb and 5 by 5 in left upper and lower limbs. He did not have any other signs and symptoms. So our diagnosis was acute stroke syndrome. He had right hemiparesis with right hemianopia, localization to the posterior circulation stroke. Pons we thought of because of hemiparesis, but he did not have any other cranial nerve deficit, but it's unlikely. So thalamus and occipital lobe is the only thing we thought of, which is actually going to the localization of posterior cerebral artery. So our MRI brain with contrast also showed the same thing. He had a stroke in the right thalamus with the involvement of the occipital lobe as well as the hippocampus, suggestive of the findings that we found. Posterior circulation stroke involving temporal lobe, occipital lobe, and thalamus. Artery involved is posterior cerebral artery. So we thought it's a normal diabetes related or chronic alcohol related atherosclerotic causing this stroke, but then much to our surprise on basic workup, we found that his hemoglobin was 19.0 and repeating hemoglobin also it was like 19.6 and then 18.9 with a total count of 14,000 and platelets of 2,40,000. Other investigations were normal. So PCV we did it. PCV was found to have 59.6 and then erythropoietin assay showed 1.9 which is low. So normal is 2.6 to 34. So then we went ahead and did bone marrow and JAK-STAT mutation which is awaited. The bone marrow actually didn't show any hypercellularity or anything except for mild lymphocytosis. So our diagnosis changed to polycythemia, probable polycythemia vera because erythropoietin is low, which is manifesting as a thrombosis of the posterior cerebral artery. So I'll be talking about polycythemia and polycythemia vera. So polycythemia is refers to the increased hemoglobin concentration or hematocrit in peripheral blood. So incidence is 0.01 to 2.61 per 1 lakh people. Prevalence is 0.49 to 46 per 1 lakh people. Median age of diagnosis 64 years. Our patient age is 53. So usually 25% of diagnosis occurs before 50 years of age. So risk factors for polycythemia, the non-modifiable risk factors are older age, male sex, white race, and European descent. So in European descent, this polycythemia is much more common. The modifiable risk factors are smoking, obesity, and hypertension. So this hypertension mainly because of renal artery stenosis. Because of that, there is increased erythropoietin. So coming to the post-stroke and polycythemia vera. So the presentation of polycythemia vera, we can see the percentage. So the most common presentation is fatigue followed by insomnia and pruritus, then concentration problems, and rest of the findings are actually very less. Arterial thrombosis and venous thrombosis are less than 20%. So our patient had arterial thrombosis of posterior cerebral artery. So these are all articles which say that the stroke could be initial presentation of polycythemia vera without any prior fatigue or other complaints. So then coming to the polycythemia features, the base stuff they can have, here we have seen that because of the increased RBC, we can have these presentations. This pruritus is mainly because of along with the erythropoiesis, they can also have more basophils, and because of that there is increased list of histamine causing pruritus. And because the hemoglobin is very high and the blood is viscous, they can have visual disturbance, headache, and because RBC mass is very high, they can have hemolysis, which can result in gout also. So this too much viscosity can result in the thrombosis, which can present as stroke, gangrene, DVT, and myocardial infarction. So now coming to the diagnostic approach. So whenever we see a patient with high hemoglobin or hematocrit, we will check for the erythropoietin levels, which is, if it is low, it is almost suggestive of polycythemia vera, which is confirmed by JAK-STAT mutation. If it is still, if it's elevated, then we should look for the other secondary cause of the polycythemia vera. If it's a smoker, then likely to be a smoker's related, or it could be related to COPD or high altitude, or the patient is having intracardiac shunt. If these also is negative, then we should think of tumors producing the erythropoietin, which is usually renal cell carcinoma or cerebral hemangioma or uterine leiomyoma. So coming to the diagnostic approach, the diagnosis is mainly based on the hemoglobin, hematocrit, bone marrow, and JAK-STAT mutation. So all three major criteria are the first two, and minor criteria should be present. So the hemoglobin more than 16.5 in men and 16 in women, with the hematocrit more than 49 and 48% respectively should be present. Our bone marrow biopsy should show hypercellularity should be present, or the presence of JAK-STAT mutation. So our patient didn't fulfill the major criteria. He had one minor criteria and hemoglobin was high. We are awaiting the JAK-STAT mutation. So here they've also mentioned that bone marrow biopsy may not be required if they have a persistent erythrocytosis more than 18.5, which was actually present in our patient on 3 occasions with the increased hematocrit. So we are almost all sure of polycythemia vera. So now coming to the prognostic score, this is the mutation enhanced international prognostic score. So they have 4 variables in this. Based upon this, they have graded the prognosis. In this, 4 variables are involved. One is age more than 60 years, WBC count more than 11,000, abnormal karyotype, and SRSF2 mutation. So our patient had one risk factor as of now. The mutation analysis is still awaited. His WBC count was 14,000 and his age is 53 years. So based upon this points, we can see that if the 0 to 1 points, there is a low risk. The survival is actually better compared to the other. So with the patient having more than or 4 points, the median survival is only 5 years. Whereas with the low risk patient, it's actually 25.3 years. So with this, actually, we'll be able to tell the patients regarding the prognosis. So now coming to the treatment of polycythemia, this is taken from American Journal of Hematology. So the target hematocrit is less than 45, and it should be with periodic phlebotomy, we should keep it at a target. So all patients with suspected polycythemia vera, we should have low dose aspirin. Based upon the prognostic score with the risk factor that we've seen below, they'll be assessing as low risk disease and high risk disease. Based upon this, they will assess whether low dose aspirin is enough or further anticoagulation is needed or not. So usually for venous thrombosis, systemic anticoagulation is indicated, and for the arterial thrombosis history, twice daily aspirin they have advised. For our patient, we gave only single antiplatelet because he had hemorrhagic transformation in the infarct area, so we were not able to give twice daily aspirin. And once the definite diagnosis reached, for high-risk patient, we should also consider hydroxyurea and other definite therapies for polycythemia. So why PCV target 45%? So this is a study done in 2014 where they looked at the cardiovascular events and with the target of reaching hematocrit. So the population was JAK-STAT positive polycythemia vera patients receiving either phlebotomy or aspirin or hydroxyurea or regulator interferon. The intervention arm included intensive treatment arm with a target PCV less than 45%. Control arm was low hematocrit group with a PCV target of more than 45%. Outcome was death from cardiovascular cause or thrombotic events. The time duration follow-up was 31 months. So this is the outcome table. Here we can see the primary endpoint. It's 4 in the high hematocrit group compared to the low hematocrit group, and the cardiovascular events is also coming to more in the high hematocrit group. The NNT came was 8. So we can say that if the PCV target is less than 45%, we can actually prevent the major cardiovascular events and the thrombotic events. So this is the reason why we target of PCV 45%. So follow-up, this is mentioned that every 3 to 6 months with a routine physical examination. So this is for patients who have been started at definite management. So our patient still on the evaluation. So he's been advised to follow up after 2 weeks. After the results, he'll be started on definite management. So our patient underwent 2 phlebotomies. Discharged hemoglobin was 14.1 with a PCV of 42.5%. He did not have one. He had actually one WBC more than 14,000, and other things are awaited. He was on single day aspirin because he had hemorrhagic transformation. He was advised to be followed up after 2 weeks. So learning points, I wanted to look at the clinical presentation, how to approach the polycythemia, prognostic score, PCV target, and follow. Thank you.
Questions? Patient presented with right-sided bone in the semicircle and right hemiparesis.
Yes.
And
Sir?
and the MRI showed
MRI showed infarct in the left thalamus, occipital lobe, and temporal lobe, and MRI also showed cutoff in the second cutoff.
MRI angiogram.
MRI angiogram, I didn't put it up, so it showed a cutoff in the P2 segment of the left PC.